clinically, and I think all of the doctors at the clinic will see patients who are overly avoiding food, and they really don't need to be. Hey everyone, this is Dr. Michael Ruscio, and today let's cover a number of very interesting studies in gut health that help us to better understand how to optimize our gut health and therefore potentially have better mental clarity, focus, sleep, mood, endocrine function, obviously better digestion, and even potentially have clearer skin and less joint pain. Now, I know that sounds like a tall order, but let's look at what's on the menu today for these new studies that I think you need to know about so as to better understand your gut health and therefore how to reap all the secondary benefits from having optimal digestive health. Sodium butyrate for inflammatory bowel disease in children, H. pylori and IBS risk, H. pylori and Barrett's esophagitis risk. Does adding fiber to a low FODMAP diet improve the outcomes or make them worse? Prebiotics for blood sugar regulation, dysbiosis and inflammatory bowel disease, adverse childhood events and risk for IBS. Elimination diets for EOE or eosinophilic esophagitis, this feeling like you have something stuck in your throat. CBD for IBS, very interesting study. Does SIBO increase Crohn's disease relapse risk? A study looking at the gut-brain axis trying to tell us, is it morely brain to gut or gut to brain? FMT or fecal transplant for ulcerative colitis, and another study comparing FMT versus steroids for ulcerative colitis. Antibiotic use in kids, and what are the long-term health impacts of using antibiotics in children. And finally, we'll wrap up with a study looking at abdominal massage for constipation. All of these studies come from the newly published research literature. As a gut geek, these are all very interesting to me. I hope they will be as interesting to you. And I also want to preface before we go into these studies, these are all either randomized controlled trials or meta-analyses. So we're not going to pull you into speculation. Every one of these studies will tell you what happens when someone similar to you undergoes an intervention, what happens, or even better yet still, maybe there are 10 like studies. If we summarize those into a meta-analysis, what is the trend in the data? So this is a hopefully very respectful articulation of science that won't, again, pull you into any sort of speculation. And the first study, can butyrate improve inflammatory bowel disease in children? The intervention was 72 pediatric patients with inflammatory bowel disease randomized to either standard medication plus placebo or standard medication plus sodium butyrate at 300 milligrams per day. That's probably about 4 capsules for most formulas. Compared to placebo, sodium butyrate led to no difference in clinical remission or in fecal calprotectin. Now, as a quick aside, on butyrate, I think there is ample evidence to experiment with butyrate, and it is something that in a controlled setting in the clinic, I am having some patients trial to see how appreciable the clinical signal is. So even though this study did not find benefit, I think there is adequate support in the body of data totally or at large to support a trial with butyrate, also especially because it is an inexpensive intervention. The next study, does H. pylori increase the risk of IBS or irritable bowel? Now, this was a meta-analysis summarizing 13 studies of about 13,000 individuals. And what they found was H. pylori infection was associated with a 1.5 times increased risk of having IBS-D or diarrhea type IBS, but interestingly, not for IBS in general. So a faint signal of association between H. pylori and IBS. What's interesting about H. pylori is you see discordance in the data regarding how it impacts certain facets of immune function. And this might be because H. pylori could be a proxy for a dirtier environment, meaning a person, especially a child, who's exposed to more dirt and bacterium may have a higher incidence of H. pylori colonization. And along with that increased exposure, they actually have better training or attunement of their immune system, therefore improved immune outcomes as an adult. In this study, there was an association to diarrheal IBS, but not IBS at large. So what exactly this means, you need to take on a case-by-case basis, but at least we have some clarification with how H. pylori maps on to IBS risk. And here's a good example of the other point I was just making. Is H. pylori associated with Barrett's esophagitis? Again, meta-analysis summarizing 24 studies of 1.3 million participants. Patients with Barrett's esophagitis had a lower prevalence of H. pylori. So perhaps H. pylori was protective. Specifically, the cytotoxic associated gene A, or CAG-A positivity, was associated with a 75% reduced risk of Barrett's. Now, this cytotoxic associated gene A is a type of H. pylori that we think is more virulent, perhaps more pathogenic. And interestingly, what you're seeing here is this H. pylori CAG-A, so H. pylori type CAG-A, subtype CAG-A, was actually protective against Barrett's esophagitis, which is when someone has reflux that causes dysplastic changes in the throat, which can become precancerous. So certainly a condition you do not want. And H. pylori is thought to potentially increase stomach acid, although this study would suggest that H. pylori is having a protective effect by perhaps lowering stomach acid. And what's happening here is it may not be quite as simple as H. pylori does or does not increase stomach acid, but depending on the portion of the stomach in which H. pylori is colonizing, that may impact whether there's an increase or a decrease in the H. pylori, or I'm sorry, in the stomach acid. All that being said, was I think the most interesting about this finding is that the thought to be most pathogenic form of H. pylori actually had a protective effect against Barrett's esophagitis. This is why it's so important to discuss these findings with your doctor and have a clinician who looks at these things both pragmatically and through an evidence-based perspective. So in this case, H. pylori actually reduced the prevalence of this sort of reflux-associated Barrett's esophagitis. And remember, that's a meta-analysis, so that's not cherry-picking one study. This is very interesting because it tells us what the data are showing kind of on the aggregate. The next study, does adding supplemental fiber to a low FODMAP diet make the diet more or less effective? This was a randomized control trial in 26 IBS patients. They were placed on a low FODMAP diet and then randomized to one of 3 groups for 2 weeks. And then, this is what's most compelling about this study, there was a crossover. So people had a washout period and then they went into the other group. So we really control for what you could call a selection bias, meaning perhaps the groups were skewed in such a way where the finding was more group dependent than it was intervention dependent. When you do a crossover design, you guard against any sort of selection or group bias. So really great study here. Now, what was given was either a 23 gram essentially control or a 33 gram of sugarcane fiber or a higher dose of sugarcane fiber plus resistant starch. So we have our control, we have sugarcane fiber, we have sugarcane fiber plus resistant starch. All groups experienced improvements in IBS scores, but the addition of the sugarcane fiber increased stool volume. This makes sense. We know that the best area for fiber improving GI health is for constipation and regularity, and for stool bulk and form. So to see increased stool volume makes complete sense. Here's what I found most interesting about this study. The resistant starch had no effect. Why I feel this to be salient is there are some groups that almost have a religious belief in the impacts of resistant starch due to their function as a prebiotic. And what this study shows us, at least as it pertains to a low FODMAP diet and its impact on regularity and IBS, is that resistant starch doesn't seem to be any better than sort of a standard fiber. So if you're on low FODMAP, you may notice that your bowels actually improve. This is, at least in my clinical observation, one grouping of individuals. However, for some, they will say, I am less bloated, I feel less distended, but I feel more constipated. This is where this study has applicability, because you could then add a fiber and you don't seem to have risk of flaring of some of the symptoms. Now, I'd also recommend that you look at your sort of treatment history. And if you've tried a fiber in the past, psyllium, Citracel, Metamucil, something like this, and you've noticed that it flared you, then you may want to be a little bit more cautious with the use of fiber. However, keep in mind that if you're doing this fiber addition in the context of a low FODMAP diet, that may actually allow you to reap all of the benefits and really mitigate against any of the side effects that can be associated with fiber, which are mainly either flaring of constipation in some, or this feeling of bloating and distension. So if you're on low FODMAP, it seems to be working, but you're a little bit constipated, consider the addition of fiber in light of this very well-performed randomized control crossover trial. The next study is trying to answer the question, can prebiotics improve blood sugar regulation? Again, another meta-analysis of 46 randomized control trials on the effect of oligosaccharides, a prebiotic, on glucose regulation. Oligosaccharides led to improvements in fasting glucose, a reduction of 5 points. Fasting insulin, albeit a small effect size, fasting insulin, and hemoglobin A1C. The positive effects of oligosaccharides were more notable, not really too surprising, in patients with the higher degree of metabolic derangement as seen in obesity and diabetes. Perhaps one of the most powerful impacts that we see from prebiotics is on blood sugar regulation. So this study really is not surprising to me. One thing to bear in mind, if the dose of prebiotics is too high, this is where adverse gastrointestinal side effects tend to come in. Now, 3 to 5 grams per day might be the sweet spot for which we have a favorable impact on the gut microbiota, a favorable impact on blood glucose regulation, but we don't see an increase or an appreciable increase in gastrointestinal side effects. Also keep in mind that when starting on a prebiotic, there can be a transient, perhaps week or so, where you have some increased gas and flatulence. This is not necessarily abnormal, so it's important that you don't jump ship too quickly and say, oh my God, I'm gassy, right? Because part of this is just your gut microbiota being given a higher amount of prebiotic substrate that it can then metabolize into things like short-chain fatty acids. And as your gut microbiota is sort of adapting to this change in food substrate, there can be some gas as a transient reaction. If that reaction lasts more than a week, I would say 2 max, that indicates it may not be a good fit for you, so I would back off. Also bear in mind the dose. Some studies, I believe, have used up to 20 grams per day of prebiotics, and I would expect a lot of people to have adverse gastrointestinal side effects from that dosage. 3 to 5 may be the sweet spot. Also, keep in mind that you need to use enough to have an effect. So if you're using 0.5 grams and saying, well, that seems to be tolerated, it probably is, because it's almost like a thimbleful and may not be enough to really exert any positive impact. Alrighty, the next study. Can the presence of pathogenic bacteria tell us anything about ulcerative colitis and UC risk? The intervention here looked at 40 ulcerative colitis patients and 20 healthy controls. All underwent colonic biopsies, so sampling from the colon tissue essentially, or lumen, to assess for various pathogens. Compared to healthy controls, UC or ulcerative colitis patients had increased pathogenic E. coli. Not all E. coli is pathogenic. So pathogenic E. coli, 28% versus 0%. So about 1/3 of individuals. An increase in H. pylori, 7.5% versus 0%. So now we're seeing H. pylori potentially being deleterious. And no difference in Clostridium difficile, 0% versus 0%. The one thing to be careful about here is this is not telling us anything causal. This is observational data. So it's giving us association information, but not necessarily cause effect. What we need to be able to more confidently comment on cause effect would be a prospective going forward in time analysis to see how the differences in the microbiota translate to risk of development of UC. Once you have the UC, it's a little bit harder to know, are those bystander findings or are they causal findings? So just important to keep this in mind, mainly because in the realm of functional GI, there is this egregious error, and this is in functional GI care, but specifically of this over treatment of the labs while discounting the individual, their symptoms, and their history. This is important to keep in mind because much of what we are learning in how microbiota findings map onto health is early stage, in its nascency. We are not sure what is cause, what is effect. So before we go rushing in with antibiotics and antimicrobials and trying to increase this and decrease that, we have to take a moment and look at the context of the patient, again, because the data here are not complete enough to confidently inform treatment decisions in most areas of functional GI. Okay, the next study. Do adverse childhood events increase IBS risk? You may have heard some of this argument that, namely, childhood trauma could correlate with constipation. So let's see what this meta-analysis of 15 studies looking at 270,000 participants found. This study did not find a clear association between risk of developing IBS and childhood traumatic events. However, when assessed by gender, females with traumatic childhood events were 2.2 times increased, or at 2.2 times increased risk of developing IBS, whereas this association was not found in males. So there might be a gender-specific sort of amenability to childhood traumatic events and IBS. Other data have found that childhood trauma does correlate with constipation. This study is looking at IBS more broadly. What you do about that is a bit more, well, this study did not attempt to answer that. So you want to take that obviously on a case-by-case basis, but certainly I would say in the clinic, we have seen therapy of various sorts, whether it be CBT, limbic retraining, and in some cases, people have even experimented with psychedelics with a therapist, and really any intervention that can help with dealing with the prior trauma seems to have a positive impact on IBS. So if that is you and this is something you haven't addressed, this might hold one of the key elements to improving your IBS. The next study looked at, can an elimination diets help with the treatment of EOE? Now, what is EOE, eosinophilic esophagitis? This is essentially where immune cells infiltrate the esophagus and can cause inflammation. So eosinophil, immune cell, esophagitis, inflammation in the esophagus. And food triggers are known to be one of the primary causes here, leading to this feeling of something stuck in my throat. And oftentimes it's not that something is stuck in your throat, it's that you have this inflammation residually that makes it feel as if there's something stuck in your throat. The intervention here was a retrospective, so looking back in time, analysis of 213 patients with eosinophilic esophagitis. They all completed a 6-food elimination diet, avoiding milk, wheat, soy, eggs, tree nuts, peanuts, fish, and shellfish. Here's the few key aspects. The elimination diet led to a 58% response rate on the endoscopic findings, so visually, and a 42% reduction in symptoms. Here's the key thing. Upon reintroduction, 69% of patients had only one food trigger. Most common were milk, wheat, and soy. Why that last point matters is so much is because clinically, and I think all of the doctors at the clinic will see patients who are overly avoiding food. They read about low FODMAP, they read about low carb, they read about low histamine, they read about low salicylate, they read about low oxalate and low lectin, and they're progressively avoiding all of these foods, and they really don't need to be. So it's important to, yes, pay attention to your diet, see what triggers you, do some elimination and experimentation, but then bring foods back in because it's likely not all of the foods in the grouping of low FODMAP or histamine or carb or whatever. And this is crucial because you don't want to be overly avoiding food. This is a serious problem amongst those who are educated on healthcare. They know all about what they should not do, and it can skew into this perspective of an unhealthy relationship with food and overly avoiding food. Okay, can CBD improve pain in IBS? The intervention here was a randomized control trial, again with that crossover that we love to see. 32 IBS patients were randomized to either a placebo chewing gum or a CBD chewing gum, the CBD containing 50 milligrams, so I consider that a sufficient dose. The CBD chewing gum did not lead to less abdominal pain when compared to placebo chewing gum. This is a very interesting finding. There are data showing that CBD does help IBS, and I say that as someone who was a bit skeptical of CBD initially, just given sort of the fanfare, and I have clearly observed that when there is market demand, meaning people want something, there are companies that will pop up to service that demand, irrespective of if the intervention is actually helpful. Well, how can that be? Because placebo is very powerful, and it's been well documented that therapies that have later been proven ineffective were all the rage for 6 months, a year, 2 years. And this is because if everyone's chatting about something and then you try it with this positive expectation, the placebo will likely lead you to believe there was this positive effect. Now, within reason, I suppose a degree of that isn't the worst thing. We can use placebo in a positive way, but it can also be leveraged in a negative way for the financial gain of others. And this is what we want to be careful about. That's why I was a bit apprehensive about CBD initially, although upon reviewing literature, there are some areas for which CBD has been found helpful. With GI, there are some data. This is one data point finding, at least for pain in IBS, CBD did not offer benefit. What about SIBO, small intestinal bacterial overgrowth, and the risk of Crohn's relapse? This study, again, retrospective, going back in time, so not quite as high of a quality of data, looked at 73 patients with asymptomatic Crohn's, meaning their Crohn's was in remission, and they were all given a lactulose SIBO breath test. 47% tested positive for SIBO. After 18 months, Crohn's patients who relapsed had a higher prevalence of SIBO compared to those who did not relapse. So 63% of those who relapsed had SIBO, 37% who relapsed did not have SIBO. So SIBO was associated with a 2.8% increased risk of celiac disease. So what does this tell us? This tells us that we can see SIBO inside of inflammatory bowel disease, and this imbalance, this overgrowth of bacteria, may increase your risk of a relapse. So it's one data point to consider as you're trying to reduce the likelihood of having a relapse of Crohn's disease. The next study looked at the gut-brain axis and its relationship to inflammatory bowel disease. Another meta-analysis of 12 studies looking at about 9,000 inflammatory bowel disease patients. Anxiety or depression were associated with worse IBD, and this was indexed by either being hospitalized for the inflammatory bowel disease or requiring escalation of IBD therapy. Conversely, active IBD was associated with increased risk of developing anxiety or depression. This is the gut-brain connection, and it's important to clarify, probably obvious, but just to clarify it nonetheless, that this is a bidirectional relationship, meaning active inflammation in the GI seems to be somewhat causal to things like anxiety and depression, and this is supported by the fact that treatment data, namely probiotic interventional trials, have shown the ability to improve anxiety and depression. However, anxiety and depression themselves seem to predispose for flaring of things like IBS and IBD. And perhaps some of that anxiety and depression come from lifestyle imbalances, if you will, or prior trauma, like we discussed earlier. So depending on the individual, we want to read their history and see what areas does this person need support. If there are, let's say, a few imbalances in their lifestyle, they don't sleep enough, they have an unhealthy relationship, they have lots of stress, they're not getting any exercise, they're not getting any time in nature. All of those may not be equally simple to fix, but we can adjust the levers that are the lowest hanging fruit and help with the brain-gut connection. Conversely, if most of those boxes are checked, we may want to intervene at the level of the gut using something like probiotics as just one example of a simple and effective therapy in GI that may improve what's going on in the gut, let's say IBD in this case, and also have the second order benefit of improving mood. The next study looked at, can FMT or fecal microbiota transplant improve ulcerative colitis? I've commented before that I feel this will be the next application of FMT that gains FDA approval, and it's data like this that support that thinking. The intervention here was a meta-analysis summarizing 9 randomized control trials of 425 ulcerative colitis patients. They were randomized to the control group, placebo, or a fecal microbiota transplant, and when compared to the controls, the FMT led to higher rates of clinical remission, nearly twice as much, 40 versus 22, endoscopic remission, again about twice as much, 17 versus 9, but also a higher incidence of serious adverse events, 10% versus 5. FMT was more effective when delivered into the lower GI, when the FMT dose was over 300 grams, and when the fecal specimens came from multiple donors, therefore presumably the highest diversity of different bacteria being presented into the new GI of the recipient. Now let's juxtapose that and keep in mind the serious adverse events with this next study, comparing steroid, so glucocorticoid steroids, to FMT in the treatment, again, of ulcerative colitis. The intervention here was 122 patients with active, mild to moderate UC given, again, either glucocorticoid steroids, prednisone, or FMT. After 3 months, when compared to the steroid group, there were similar clinical and endoscopic remission findings, 55 versus 48, but there were fewer adverse events in the FMT group by about half, so 23 versus 58. So we have to sort of weigh these findings, where the last study found that FMT is associated with a higher incidence of serious adverse events, and those should not be swept under the rug. 5% versus 10%. Yes. We should also look here that the glucocorticosteroids had a 58% chance of adverse events, whereas the FMT had a 23% likelihood of adverse events. Now, this is adverse events versus serious adverse events, so the context here does matter, and it's not necessarily a direct comparison because one is more serious, one is more general adverse events. But nonetheless, we want to be careful in looking at not only what are the negative events or adverse events associated with the FMT, but also how does that compare to the risk of the therapy you could use instead of the FMT. So we have to compare, not just in isolation. Well, there's a 5% chance of serious adverse events with FMT. In a vacuum, that may cause one to say, well, I am not going to do an FMT. However, if we look at the fact that there's a 58% risk of adverse events, albeit not serious, but adverse events nonetheless with steroids, that helps give us a better sort of risk assignment and ability to weight what therapy we want to use. And these are things that you can discuss with your doctor, but hopefully empower you if you do have ulcerative colitis and you're trying to determine what therapies do you want to use next. And this next study asks and attempts to answer a very important question. Does early life antibiotic use increase the risk of chronic disease? Again, a meta-analysis of 160 observational studies of 22 million children. Antibiotic exposure, especially in the first 2 years of life, was associated with an increased risk of asthma, allergy, wheezing, psoriasis, arthritis, atopic dermatitis, loosely aka as eczema, food allergy, neurodevelopmental disorders, obesity, and autism. No association, surprisingly, was found between antibiotics and inflammatory bowel disease, an issue in the gut, celiac disease, an issue in the gut, type 1 diabetes, or ADHD. Again, these are observational data, so they don't tell us cause. There could be other things that led the child to need the antibiotics, like an infection, and it could be the infection that's actually the factor causing the risk here. So we want to be careful on the one hand. On the other, we want to make sure that we are as discriminant with the early application of antibiotics as possible. I discussed this in Healthy Gut, Healthy You, and I sort of provide a decision framework for how to navigate this with your doctor. Said simply, we want to avoid sort of the liberal use of antibiotics and make sure that if they are used, they will be used selectively, because there may be some negative impacts. And like we've discussed in the podcast before, the early developmental window, the first 2 to 4 years of life, is the most sensitive time to either positively or negatively impact the gut microbiota, and related to that, the immune system, which is why we see all these immune-mediated disorders popping up. So we want to be careful. We don't want to be dogmatic and say never an antibiotic, because that could also be bad, but we want to be discerning with their use. And final study here. Can abdominal massage, rubbing your belly, improve constipation? The intervention here, a randomized control trial of 74 patients with functional constipation, were either given a placebo as abdominal ultrasound. What a smart placebo. What a great job by the researchers. Imagine laying on a table and an ultrasound tech is doing this thing with the ultrasound up and down in your stomach, that's probably a pretty powerful placebo. Plus lifestyle advice, or abdominal massage plus lifestyle advice. So again, they really, I think, did an excellent job with a smart placebo. And after 1 month, compared to this ultrasound placebo, abdominal massage led to reduced constipation severity, 70% reduction in the massage group, 28% in the placebo, improved quality of life, 56% as compared to 38%, and increased stool frequency, 70% versus 43%. So, if you are constipated, abdominal self-massage is a simple and free intervention to help impart some movement into the tissues of the GI. And for whatever reason, whether it be someone has a tortuous colon, or they have a lack of motility, or they maybe have adhesions, or maybe they're not moving enough and exercising. And so the movement of the massage provides the movement they're not getting otherwise through doing things like sit-ups or squats or whatever. For whatever the reason is, abdominal massage has been shown to be effective for constipation. And this is something that we refer patients to do at the clinic, and it certainly is helpful for some. So bear this in mind if you are constipated. You can fairly easily look up a tutorial on YouTube for how to do this. I don't believe it is something that's a very specific protocol. What seems to be most important is just consistency in performing this abdominal massage to get things moving. And if stool is getting stuck at all anywhere in the colon, that movement may help kind of unstick it and allow the stool to move, to pass, and to help with regularity. So those are the studies I wanted to cover. I hope these help you appreciate the deeply important impact that your gut has on so many facets of your health, from neurological to dermatological to immune, and navigate all of the decisions you have to make to optimize your gut health. I'd be very curious in the comments below to hear your thoughts. And also, if this was helpful, please subscribe and please share it with someone else. I really want these ideas to reach more people because there's just so much incorrect or cherry-picked information on the internet, especially regarding gut health. So if we can give people these research studies that are the high-quality meta-analyses and randomized control trials, this can guard against people being misled by a guru or a supplement company, cherry-picking the one study that supports their beliefs, sharing that with you, even though it's totally discordant to what most of the good evidence may support. So your help in getting these ideas and research out to more people is deeply appreciated, so please do share. Okay, this is Dr. Michael Ruscio, and I'll talk to you next time.